the drunk walk, impaired judgment, slurred speech, and mood and behavior and personality changes. These are those guys, the agitated, belligerent drunks. All right, so blood alcohol, 0.20 to 0.30. Everything we've already talked about, plus more lack of coordination, incoherent thoughts, confusion, nausea, vomiting, hypothermia, and nystagmus. So at levels above 0.30, and for those of you who are hospital-based, that's above 300. Stupor, loss of consciousness, and once you get above about 350, possibility of coma, respiratory depression, and even death. So, common findings in trauma. A lot of times with trauma patients, you can have the altered level of consciousness. Okay, well that could be a traumatic brain injury, that could be shock, or they could be drunk. Alcohol can cause that alteration in level of consciousness, but what studies have shown is that with mild intoxication, it doesn't affect the GCS. When you get to above 0.25%, it can actually affect the GCS by up to 1 point in each area. So, but what we do know is that as they sober up, that GCS improves. Mood and behavior changes. Okay, your patient's agitated. It could be a manifestation of a traumatic brain injury or shock, or they could be agitated because they have alcohol on board. Hypothermia. Our patients with hypothermia who are trauma have really poor outcomes. Their bodies don't heal, they don't respond to shock well if they're hypothermic. So if they're already hypothermic and now they have alcohol on board, they take on the ambient temperature of the room. Really poor outcomes. So lactic acidosis. We can have an increase in lactic acidosis in trauma patients due to the shock response. Well, alcohol can also increase lactic acidosis. So if you have a combination, it can be a really bad situation for the patient. Hypotension, of course, present in shock, but also if you have a severely intoxicated patient, their blood pressure may be bottoming out. So sometimes with alcohol on board, it can be difficult to differentiate between what the alcohol is causing and what is actually caused by the trauma. Overall, treat it like it's trauma. It's certainly not going to hurt them. Tachycardia, of course, present in shock, but can also be a result of large volume losses from vomiting from intoxication. And respiratory depression. Of course, traumatic brain injury or chest trauma can cause alterations to the respiratory system, so can alcohol intoxication. All right, so I've got a case study for you. On December 25th of 2009, we had a 31-year-old female who was a restrained driver at the 57 and 60 junction. She struck a lamppost, rolled over, down an embankment, and took out the big sand-filled barrels that they usually put at the exits and entryways to the freeway. She had extensive damage to the vehicle. EMS units that responded were mostly LA County. It was engine 120, ALS 5119, and ambulance 8333. Scene arrival time was 23:46. They found the patient lying across the driver's seat with a decreased LOC. Her GCS was 3. She had abrasions and lacerations to both her hands, agonal respirations with a respiratory rate of about 8. Smell of ETOH, and extrication was necessary. They had initiated spinal precautions, and once they did that, her respiratory rate got a little bit better and her GCS improved. Not greatly. She was now at a 5 instead of a 3, but a little bit of an improvement. Her blood pressure, 161/104. Ooh, head injury. Heart rate, 96. Respiratory rate, better, 16. And total scene time was 14 minutes from the EDMS arrival until the time they took off. So great job to them. They got her out of the car quick, packaged her up, off they go. This is the car they cut her out of. All right, so arrival to the ED at 00:25 on the day after Christmas in the morning. Initial vital signs, 160/80, 76. Respiratory assistance at this point with a BVM because she still didn't have good breathing effort. She was intubated. FAST scan was negative, so no abdominal trauma that we found initially. Base deficit was -8, which is not super high, but high, or low as it may be. ETOH was 231. So she falls into that category of very intoxicated. We felt she was in such bad shape when she got to us, we contacted One Legacy and said, we've got a patient, we've got a traumatic brain injury, but the rest of her is in good shape, so you might want to come check her out. Injuries. She had a Lefort fracture. She broke most of the bones in her face. You can see the red line there. It just shows you, when she hit, she impacted the front of her face. But she also broke the mandibular ramus, bilateral zygomas, and the left orbit. So she had fractures up here, down here, and back here. She had a subarachnoid hemorrhage, an epidural hemorrhage, a diffuse axonal injury. Now, a DAI is when the gray and white matter shear apart. And it doesn't have to happen throughout the brain. One little area can cause a big injury. So it's that gray and white matter shearing where the axons actually tear. So you have your cell nucleus here. This is the axon. This is the white matter. And what happens is this shears off from the cell nucleus. When that happens, those impulses can't get through. So the brain is not responding. Nothing is getting to it. Nothing's going out. Or at least the cells that are damaged. So she had also distal right radius fracture, left metacarpal fractures, 3, 4, and 5, right metacarpal fractures, 4 and 5, a left tibial plateau avulsion fracture, a right fibular head fracture, medial malleolus fracture, scalp lac, contusion, and multiple abrasions. Now, when we have a trauma patient, we grade their injury based on the ISS, which is an International Severity Score, and we generate an actual injury severity. 1 to 15 is minor injuries, 15 to 25 is moderate, 25 and over is severe injuries, and if they're at 75, they're death. She was a 38, severely injured. Her probability of survival was only 38%. Next. All right, so 65 minutes after arrival, we actually got her out to the ICU. Hospital day 1, they put a feeding tube in, make sure she has good nutrition. Hospital day 3, they put an IVC filter in for DVT. She had 2 DVTs. Of course, we don't want those to become PEs, so got that filter in. Hospital day 4, ORIF of the mandible with a jaw wiring and a tracheostomy. Hospital day 10, they went ahead and did an adjustment of the ORIF of her jaw and fixed her arm fractures. She was discharged on hospital day 20 to Kindred. And at the time of discharge, she was only able to blink in response to questions and respond to painful stimuli. So, okay, you get a pinch, you get a little noxious stimuli, she grimace. She spent 2 months at Kindred, and she had intensive physical, speech, and occupational therapies. Then, after that, she went to Winways, an outpatient intensive rehab therapy, and stayed with them for a while. Today, she can speak clearly. She cares for herself with minimal assistance. She started the Acquired Brain Injury Program at Coastline Communities Colleges. She celebrated her 32nd birthday, and she hopes to start driving again soon. She's actually gotten to the point where she can take her driving test. She has the support of her parents, her sisters, and her 4 daughters. Her daughters are 4, 7, 9, and 11. She doesn't remember the accident or some of the things from before. She continues with physical therapy, loves to knit, wants to write children's books, and she's just looking forward to what comes next. And she's very, very grateful to the pre-hospital personnel who were able to help her. Because until this event, she didn't realize where her life was. And thankfully, she was the only one injured in this accident. But any kind of traumatic injury is life-changing for not only the patient, but the family too. And I would like to ask you to watch this for just a minute.